Thank you, Basak and Somashila. So let's go on to the talk of management of dry eye. As you all know, the dry eye has been defined as it's a multifactorial disease and is accompanied by tear film instability, and there is an increased osmolarity accompanied with inflammation of ocular surface, and it leads to symptoms of discomfort and visual disturbances. And the dry eye prevalence varies from country to country, and it's more prevalent in Asian countries. Prevalence rate varies from 5% to 37% in different countries, and prevalence increases with age, and more frequently it's seen in women as compared to men. In India, there's only one study showing the prevalence rate of around 18%. And Meibomian gland disease is an important subset of dry eye patient, which is associated with age-related increase in prevalence. In general population, prevalence of MGD is around 30 to 68%. And evaporative type of dry eye is most common type of dry eye, and almost 86% of patients with dry eye have Meibomian gland disease. Before we understand the treatment of dry eye disease, we have to understand the mechanisms underlying the dry eye disease. So the dry eye is mainly divided into two subsets of category: the Meibomian gland disease, or the evaporative type of dry eye, or a tear deficient dry eye, where there's a decrease in lacrimal flow. And the hallmark of dry eye disease is increased osmolarity of tears, which will activate various inflammatory cytokines onto the ocular surface, which leads to ocular surface damage and tear film instability. Initially, the ocular surface inflammation will lead to increased tear flow, but over a period of time, there is a neurogenic inflammation which leads to a reflex block of tear secretions. And this chart, it's a quite busy chart. It shows the different etiology of decreased tear flow as well as various etiology of Meibomian gland disease. So before we go on to the management, we have to diagnose the dry eye disease. For that, history and systemic examination of the patient, various questionnaires, and ocular surface disease index we have to ask from the patients. And these are the various tests we should be conducting in a specific row. And if we have to do a detailed clinical examination of the patient, the examination of the lid margin, the lid Meibomian gland disease, opening, as well as examination of the conjunctiva, cornea, tear film, and you can see the spectrum of the disease varies from one extreme, shining cornea, to the very bone dry cornea, which can happen in Stevens-Johnson syndrome. And depending upon the signs in lids, tear film, conjunctiva, cornea, we can have different grades of the disease, from mild to moderate to severe to very severe disease, depending upon various signs and symptoms and various investigative tests like fluorescein and Shermer test, which we do. This is just to show the tear meniscus height. This is the most non-invasive test which one can do, and this we have to measure. The normal value of tear meniscus is from 0.2 to 0.3 millimeter. If you stain the surface with the fluorescein, then it may be a little higher. And this is again tear film breakup time. The normal is 10 seconds. You have to do it 3 consecutive times, and it's a very useful test to diagnose the dry eye. And of course, everybody knows about the fluorescein, rose bengal, and lissamine green staining, and we have to grade it on various Oxford grading score, as well as rose bengal and lissamine staining on von Bisserwald scale. But the recent test is, as we have told, that increased osmolarity is the hallmark of the disease. So recently, these equipment is also available in India. One can measure the tear osmolarity. Normal value of tear osmolarity is around 300 milliosmoles per liter, and anything more than 308 is taken as abnormal. We have to take the higher reading of the two eyes, anything more than, and the difference of more than 8 milliosmol between two eyes is significant. In mild dry eye, the value is up to 320. Between 320 to 340 is the moderate, and between 340 and above, it's graded as severe dry eye. But this is quite variable, just like even in controlled diabetics, you have fluctuating level of blood glucose, but HbA1c is a good indicator, but for osmolarity, there is nothing like that. So we have to, once it's abnormal, it's taken as a diagnostic, but otherwise it's doesn't rule out the diagnosis of dry eye. Another very practical test is very quick test to know the inflammation on the ocular surface is detection of matrix metalloproteinases 9. This is a very rapid test, just like 4-step test. You have to dab the tear with a strip, and just like pregnancy test, if it shows up red, it means the ocular surface inflammation is increased, and normal value if it's more than 40 nanoliter in the tear, it shows up red. That means ocular surface inflammation is increased. So we have to do all these tests in a definite sequence. You can't do it haphazardly, otherwise you will get wrong reports or wrong interpretation of these tests. And what are the current therapies available to us? These are the whole list of therapies which are available to us, but the mainstay of treatment is tear substitute and anti-inflammatory therapy. So depending upon the severity of the disease, whether it's mild, moderate, severe, or very severe, in grade 1 disease, we can just educate the patient and tell them to change their environment. If they are in very windy or in AC, they can just humidify their rooms and preserve tears. Maybe 4 to 6 times a day are good enough. And we have to control the allergic eye disease. In grade 2 disease, in addition to first level treatment, we have to add on anti-inflammatory in the form of cyclosporin 0.05% and maybe secretagogue, like in the form of, now we have rivamide available in India, which increases the mucus secretion on the ocular surface. But in very severe form, we may have to resort to oral tetracycline and even punctal plugs. But don't be in a hurry to insert punctal plug. We have to control first the ocular surface inflammation before we put on the patient to punctal plug, and we have to counsel the patient that the treatment of dry eyes, it's on a long-term basis. If they are expecting a relief in a short time, then they are under misconceptions. So counsel the patient that it will take a long time for the cyclosporin effect to come. At least use it for 3 to 6 months for any effect to come. So, so the goal of treating dry eyes, first we have to address the various risk factors or predisposing factors, and we have to make the patient comfortable and improve his or her visual function. We have to stabilize the tear film and of course control the ocular surface inflammation, and the objective indices for all these improvement will be reduced corneal staining, improvement in tear film stability in terms of improved tear film breakup time, as well as there will be decrease in osmolarity as well as ocular surface inflammation, which can be studied serially by doing osmolarity and rapid pathogen test. So first we have to address the underlying conditions. We may have to counsel the patient to humidify their environment. They should be well hydrated. If there is any, we have to tell them to blink completely and properly, and the history is very important. If they are on any medication like anti-allergics or beta blockers or diuretics, which tend to decrease the tear film, we have to modify the therapy. And if the patient is having systemic disease like Sjögren's syndrome or thyroid disease, these patients can go suddenly worse. So we have to treat their systemic disease to have a very good effect of local therapy. And now coming to the mainstay of the treatment of the dry eye is the topical topical artificial tears, and of course everybody knows it's important that their osmolarity should be closer to the normal tears and pH should be regulated, and they should have a mucomimetic, and viscosity should be good enough so that they stay on the eye for quite long time. The idea of giving artificial tears is they hydrate the ocular surface, they decrease the concentration of inflammatory cytokines, and as well as they stabilize the tear film. And preservating content of these tears is very important, and these are the various classes of polymers available in the market, and there is combination of all these polymers are also available, and studies have shown all of them work equally good, so you can choose either one of them. And there's a recent concept, osmoprotection. The tear substitute, artificial tear substitute alone, they just hydrate the surface, but they don't take into account the hydration of the cells. So the absolute particles like compatible solute like glycerol, erythritol, and carnitine, they have osmoprotective action on the ocular surface cells. So there is a dual action, hydrate the ocular surface as well as they hydrate the cells on the surface and prevent their damage and bring about the stability of ocular surface. And the preservating content of all these drops is very important. If a patient needs to put any drops for more than 4 to 6 times daily, one may have to resort to preservative-free drops, and all these preservative in the form of either benzyl ammonium chloride or even oxidized chlorocomplex, which are transient preservatives, they have significant cytotoxic damage. They lead to ocular irritation and also perpetuate the inflammatory cycle on the surface, also leads to decrease of goblet cell density and damage the corneal epithelial damage. And in terms of toxicity, the BAK is most toxic to the ocular surface, and in decreasing order of toxicity, polyquat, parborate, and puride. But again, as I said, if patient is going to use these drops for more than 4 to 6 times daily, it's better to choose preservative-free drops. And now coming to the control of surface inflammation, and in this category we have a cyclosporin, topical corticosteroids, as well as topical and systemic macrolides. As we all know, cyclosporin has a lacrimogenic action, as well as it decreases, it brings about homeostasis onto the ocular surface, prevents T-cell infiltration, as well as it blocks the action of cytokines on ocular surface, as well as it prevents apoptosis over long-term use. It also increases the goblet cell density on the ocular surface. And steroids we will use only once patient has too much discomfort. If studies have shown by Rao et al. That if we don't treat the dry eye in stage 1, it will progress on to stage 2. So it's, and subsequently, of course, we have to put these patients, once they are in stage 2, to prevent further damage, we have to put them on long-term cyclosporin. And if there is too much discomfort, we can add on a short course of steroids in the form of loteprednol twice a day for maybe 4 to 6 weeks before cyclosporin. And in cases of meibomian gland disease, tetracycline topical or systemic may be added. So dry eye could be many times silent, especially in diabetics or post-LASIK patients, as well as contact lens wearers, as they have decreased sensitivity. And osmolarity and inflammatory dry test could be very useful in diagnosis and management of these cases. So this is one representative case which is just one week apart, just on TS substitute. You can see the change in placido disc picture. There's a improvement in Myers, as well as you can see the higher order aberration also decreases. So it.
Yeah, conclude. Yeah.
Yeah, I just conclude. So it's very important that the ocular surface is brought to normal before we go on to any surgery. Even the keratometric reading will change in these cases, and it is always better to use drops for at least 2 weeks before carrying out any IOL calculations or doing any refractive surgery in these patients. So many of these patients may have dry eye could be masqueraded by these conditions, so you have to rule out conjunctival calluses, lid viper epitheliopathy, or contact lens intolerance, as well as allergic eye disease. If these are coexistent, you have to take care of them. So lid margin disease is important. These are the various...
Jain, please conclude.
So lid margin disease is very important, and these are the various options available for treatment of lid margin disease. So I'll just come to the last slide. So the role of omega-3 fatty acid is now very important in the management of dry eye disease. We have done one study which has shown that the use of omega-3 fatty acid significantly decrease in dry eye symptom, tear evaporation, along with improved meibomian gland expressibility and meibomian gland quality and contrast sensitivity. So just to conclude, dry eye is a common disorder, and its incidence and prevalence is increasing, and it is often multifactorial, significantly affecting quality of life and negatively impacts the vision, and multi-pronged approach is required to manage this disorder. Thank you very much.
Thank you, Dr. Jain.